Imagine enduring just excruciating burning pain for nearly 5 years. I mean, you've changed your laundry detergent, you've given up all those scented soaps, you've worn only loose-fitting cotton clothing.
Right, doing everything you're supposed to do.
Exactly. And, you've tried endless rounds of antibiotics and antifungal creams, but the pain is still there every single day.
Yeah, it's a complete nightmare.
It really is. And for a patient experiencing severe entrance pain, this isn't some hypothetical nightmare. It is a statistical reality caused by a notorious diagnostic trap. So, welcome to the deep dive.
Glad to be here for this one.
Today, our mission is untangling that trap. We are looking at a stack of clinical guidelines, systematic reviews, and case studies to understand how to differentiate two incredibly tricky conditions during an initial evaluation for entrance pain.
Right, specifically, we're looking at erosive lichen planus, which is often called ELP, and plasma cell vulvitis, which is also known as PCV, or Zun's vulvitis.
Yeah, and the stakes here, especially for anyone listening who might be dealing with this, or maybe you're trying to help a patient navigate it, they're incredibly high.
Oh, absolutely. When a clinician evaluates a patient presenting with these bright red, really painful mucosal patches at the vaginal entrance, ELP and PCV are the two prime suspects.
The usual suspects.
Exactly. And confusing them or misidentifying them as just some stubborn yeast infection, it can lead to devastating long-term consequences for the patient's anatomy and, their overall quality of life.
Yeah, and that timeline is what really haunts me from the sources we looked at. I mean, a patient comes in with this entrance pain, which is clinically known as dyspareunia, right?
Right, dyspareunia.
And getting the right diagnosis can literally take years. We were talking about a daily, relentless burning sensation. So, okay, let's unpack this.
Let's do it.
Let's start with what the doctor and the patient are actually seeing and feeling in that initial evaluation. I mean, why is this such an easy trap for a well-meaning clinician to fall into?
Well, the trap is set because the presenting clinical picture is practically a mirror image in those early stages. Both of these conditions frequently present with severe burning, stinging, and, as you noted, dyspareunia.
So they basically sound identical on paper.
Pretty much.
Mm-hmm.
When the clinician performs the physical exam for both ELP and PCV, they're often looking at what the medical literature calls glazed, well-demarcated erythema.
Right, which translates to
Distinct, shiny, fire engine red patches right at the vaginal introitus, or the entrance.
So you have a patient in severe distress, and the visual evidence is just a shiny red patch. And because of that visual overlap, the diagnostic delay is absolutely staggering.
Staggering is the right word for it.
Yeah, one systematic review we dug into analyzed 196 patients with plasma cell vulvitis. It showed a mean delay in diagnosis of 4.7 years.
4.7 years of active suffering. Just think about the psychological and physical toll of that duration.
That's unbelievable.
It really is. That's nearly 5 years of burning pain, painful or completely impossible intercourse, and, constant medical gaslighting or misdiagnosis before anyone figures out what is actually happening at a cellular level.
It's completely mind-boggling. I'm trying to picture the clinical dilemma. It's like looking at two identical houses with bubbling paint on the walls.
Oh, that's a good analogy.
Right, because from the outside, they look exactly the same. You assume they have the exact same problem. But inside the walls, one house just has a minor localized water leak, while the other house has a raging, aggressive termite infestation that's actively destroying the structural foundation.
Exactly.
But here is where I have to push back a little bit. If these conditions look so similar to the naked eye and both of them cause this intense burning entrance pain, how is a doctor supposed to know what they are dealing with during that initial evaluation? I mean, are they essentially just guessing?
Well, what's fascinating here is that the clues aren't always located where the pain is. The key lies in looking for subtle visual indicators elsewhere on the body. And, more importantly, understanding the distinct destructive mechanisms driving each disease.
Oh, you have to zoom out.
Exactly. It requires a clinician to pan back from that localized red patch and look at the broader systemic picture. One of these conditions is an aggressive destructive attacker, and the other is just a chronic localized irritant.
Which brings us to our first suspect in the lineup, right? Erosive lichen planus, the destructive mimic.
The termite infestation from your analogy.
Yes, exactly. So let's build a clinical profile of this condition. What is actually happening inside the immune system of someone with ELP? I'm trying to visualize how this creates those red erosions.
Sure. So erosive lichen planus is a chronic T-cell mediated autoimmune condition. Your immune system's T cells, which are, the specialized soldiers supposed to fight off foreign invaders like viruses.
Right, the good guys.
Right. But they become confused. They misidentify the patient's own tissue as a threat and start attacking the squamous epithelium, which are the cells that line the mucous membranes.
Wow, okay.
And there is a deeply fascinating immunological detail in the BHH guidelines. That's the British Association for Sexual Health and HIV.
I remember reading that part, yeah.
They note that 61% of patients with vulval ELP actually have weak circulating basement membrane zone antibodies.
Wait, hold on. Basement membrane zone antibodies. So their immune system is essentially generating weapons specifically targeted at the structural foundation of their own tissue.
Yes. The basement membrane is essentially the biological double-sided tape that holds the top layer of skin, the epithelium, firmly to the deeper dermal tissue underneath.
Okay, the double-sided tape, that makes sense.
Right. And when the immune system attacks and destroys that tape, the top layer of tissue loses its anchor. It simply detaches and sloughs off. That is the exact mechanism of erosion. That's why it is called erosive lichen planus. You are left with raw, exposed, intensely painful underlying tissue.
But if the visual clues right at the vulva are just raw red tissue, where exactly is the doctor looking next? Because the research mentioned the Delphi consensus criteria for diagnosing ELP.
Yes, the Delphi criteria.
This was this massive international effort, right? Where 73 experts like dermatologists, gynecologists, histopathologists, they all gathered to agree on how to accurately spot this condition.
And it was much needed. For a long time, there was no standardized diagnostic criteria for vulval ELP, which heavily contributed to those multi-year diagnostic delays.
Right, because everyone was just guessing.
Exactly. So the Delphi consensus established 9 supportive criteria. You need to meet at least 3 for a firm diagnosis. They looked for the well-demarcated erosions, the pain, the vaginal inflammation.
But there was one specific visual clue, right?
Yes. One of the major visual giveaways they highlighted, which a sharp clinician will look for at the margins of the redness, is something called Wickham's striae.
Wickham's striae. The sources describe it as a pale lilac, or like a mauve lace-like network at the edges of the erosions.
Yep, that's it.
But why does the body create a lacy white pattern next to an erosion? Like, what's the biological purpose there?
It's actually the body's desperate attempt at defense. That lacy white border is hyperkeratotic tissue.
Meaning extra keratin.
Exactly. Keratin is the tough, protective protein that makes up our hair and nails. When the mucosal tissue realizes it is under a severe immune attack, it basically panics and goes into overdrive, overproducing keratin to create a physical shield over the vulnerable areas.
So it's building a wall.
Building a wall, yeah. And that thickened shield appears visually as a pale, lacy, web-like pattern surrounding the raw red areas. If a clinician spots that hyperkeratotic shield, alarm bells for an autoimmune attack should be ringing loudly.
But the search for clues doesn't stop at the vulva, right? Because this is a systemic autoimmune issue, those confused T cells are circulating everywhere.
That's a crucial point. ELP is a mucocutaneous disorder, meaning those confused T cells can target any mucous membrane in the entire body.
Anywhere at all.
Anywhere. So the expert clinician will immediately ask the patient to open their mouth. They will meticulously check the oral mucosa, the inside of the cheeks, the gums, looking for those same erosions or lacy white lines.
Wow.
The attack can even manifest in the esophagus, the lacrimal ducts in the eyes, or the external auditory meatus in the ears.
Just think about that. You could have your tear ducts or your ear canals involved when your primary agonizing complaint is vaginal pain.
Yeah, it's completely unintuitive for a patient.
It really shows how deeply interconnected the whole system is.
The systemic nature of the disease is profound. There is actually a specific clinical presentation called vulvovaginal gingival syndrome, or VVG.
I saw that in the notes, yeah.
This is a highly aggressive triad where the erosive disease targets the vulva, the vagina, and the gums simultaneously. Patients with VVG present with profound soreness, dyspareunia, and often blood-stained vaginal discharge.
Because the tissue is just so fragile.
Exactly. The tissue loses all of its integrity and becomes incredibly friable, meaning it bleeds at the absolute slightest touch or friction because that anchoring basement membrane is completely gone.
Which brings us to the ultimate danger of ELP and why the clinical guidelines stress that catching it early isn't just about pain relief. I mean, it's a structural emergency. The termite damage is compounding.
Right. The defining tragedy of unmanaged ELP is architectural destruction. As these deep, immune-mediated erosions attempt to heal, the body uses scar tissue.
Because that's all it knows how to do.
Exactly. And because the vulvar and vaginal tissues rest in close proximity to one another, two raw, eroded surfaces can literally scar together. The body bridges the gap with fibrous tissue, forming synechiae, which are abnormal adhesions.
The case studies were incredibly stark about this progression. I mean, without intervention, the labia can completely fuse together, burying the clitoris entirely beneath scar tissue.
It's horrific.
Or the vaginal canal itself can completely scar over and close up, which is a condition known as complete vaginal stenosis, right?
Yes, complete stenosis. The body is essentially sealing itself shut in a misguided attempt to heal a wound that its own immune system keeps aggressively reopening.
So if ELP is this aggressive, scarring, multi-organ mucosal attacker, how does plasma cell vulvitis compare when the doctor is doing that initial evaluation? I mean, is PCV just a milder, early-stage version of the exact same autoimmune attack?
Not at all. They're completely different beasts, and this is where the diagnostic divergence becomes absolutely critical.
Okay, lay it on me.
So PCV, which was first described by Dr. Zun in 1952, is not an autoimmune attack on the basement membrane. It is categorized as an idiopathic, chronic, benign inflammation.
Idiopathic meaning we don't know why it happens.
Exactly. The medical community doesn't know the exact trigger. Theories suggest it could be an exaggerated reaction to localized friction, trapped moisture, or maybe recurrent minor infections.
Got it.
But whatever the trigger, it is a localized inflammatory response. It's not a systemic circulating T-cell attack on the tissue's foundation.
The visual profile for PCV is slightly different too, isn't it? While ELP has that lacy hyperkeratotic shield, the Wickham's striae, PCV is generally described as a solitary, well-defined, glistening red plaque, usually sitting right in the vulvar vestibule.
That's right.
And there was this one visual detail in the dermatology journals that really jumped out. They describe PCV lesions as having a distinct orange hue or featuring what they call cayenne pepper spots.
Yes, the cayenne pepper spots. If we connect this to the bigger picture, that description is a massive clue to the underlying cellular mechanics.
Sure.
Those tiny orange or red specks aren't just a change in skin coloration, they are extravasated erythrocytes.
Okay, let's break that down for the listener. Extravasated erythrocytes. What is physically happening to create that cayenne pepper look?
Well, extravasation means leaking out. Erythrocytes are red blood cells. In PCV, the tissue is in a state of chronic, localized irritation. In response, the body dilates the tiny blood vessels in that specific area to rush immune cells to the scene.
Like a localized emergency response?
Right. Over time, under the stress of chronic inflammation, those engorged vessels become leaky. Red blood cells escape the vessel walls and get trapped in the surrounding tissue.
Oh, I see.
And when those trapped red blood cells eventually break down, they leave behind their iron deposits, a compound called hemosiderin.
Huh.
So those cayenne pepper spots are essentially tiny, localized rust stains. It's iron pigment left behind by leaky blood vessels reacting to constant irritation.
Tiny rust stains embedded in the tissue. That paints such a vivid mechanical picture of what chronic inflammation actually does. And the symptoms patients experience, they perfectly match that idea of chronic localized irritation.
They do, yeah.
Looking at the data from the systematic review of PCV, 52% of patients feel burning or stinging, 44% have dyspareunia, and 41% have itching. It sounds utterly miserable.
The misery is profound, no doubt about it. But the crucial distinction from ELP is the preservation of the architecture.
Because it's not attacking the foundation.
Exactly. Because PCV is an irritation rather than an attack on the basement membrane, it is generally not associated with complete architectural destruction or vaginal stenosis.
So the double-sided tape is safe?
The double-sided tape holding the tissue together remains fully intact. It doesn't cause the labia to fuse or the vagina to scar shut. It's a benign, localized inflammatory process, not a destructive autoimmune war zone.
But here's the reality check from the clinic. We can sit here and talk about looking for cayenne pepper spots and Wickham's striae in a textbook setting. But in a real-world clinical setting, when a patient is sitting on the exam table after years of pain, the tissue is often just profoundly inflamed.
Oh, I see.
It's universally red, it's angry, it's swollen. Those subtle signs like tiny rust stains or lacy white borders might be completely obscured by sheer inflammation.
The naked eye is incredibly fallible in these scenarios. The intense inflammation acts like a smokescreen. You might not see the lacy border. The orange hue might be completely masked by bright red blood flow.
Right.
This is precisely why every single major guideline we reviewed, from BSH to the specialized vulvovaginal disorder centers, insists on one mandatory non-negotiable step:
The ultimate tiebreaker.
the biopsy. Visual inspection is simply not enough. A punch biopsy is absolutely essential for a definitive diagnosis when you're dealing with chronic, red, erosive patches causing entrance pain.
Makes sense.
If the naked eye is essentially blind here because of the inflammation, you have to look under the microscope to see what the cells are actually doing.
So let's take these two suspects to the lab, right? We take a tiny sample of that red tissue and put it under the microscope. What is the microscopic showdown between ELP and PCV? What does the pathologist actually see?
Under the microscope, the smokescreen clears entirely, and the differences become glaringly obvious.
Yeah.
Let's look at erosive lichen planus first. The pathologist will see a dense band of inflammation, but they will note it is specifically a lymphocytic inflammatory band.
Lymphocytes, meaning those confused T cells we talked about earlier, just swarming the area.
Exactly those T cells. The pathologist will also note something called irregular sawtooth acanthosis. Remember how we said the body overproduces keratin to build a shield?
Yeah, the Wickham's striae thing.
Right. Acanthosis is the thickening of the skin layers. Under the microscope, the lower levels of the skin look jagged, literally like the teeth of a saw, as the cells are radically multiplied to defend themselves.
Wow, okay.
But the absolute smoking gun for ELP is basal cell layer degeneration. The pathologist might use terms like civet bodies or liquefaction of the basal layer.
So the foundational cells are literally melting away.
They are dying and breaking down, yes.
Huh.
This is the visual, irrefutable proof that the T cells are actively destroying the basement membrane. The foundation of the house is crumbling right before our eyes.
That is the unmistakable signature of the destructive mimic. So what happens when you slide the PCV sample under the lens? How does a localized irritant look different?
Well, PCV looks entirely different cellularly. Instead of a swarm of T-cell lymphocytes, the inflammatory infiltrate is made predominantly of plasma cells.
Hence plasma cell vulvitis.
Exactly. In fact, to firmly make the diagnosis, pathologists often look for an infiltrate where greater than 50% of the immune cells are plasma cells.
And plasma cells play a different role in the immune system, right? They're the antibody factories that show up for chronic, prolonged irritation rather than acute attacks.
They are the responders to chronic annoyance, yes. Along with that dense crowd of plasma cells, the pathologist will easily spot those dilated leaky blood vessels and the hemosiderin deposits.
The iron rust stains.
Right, from the broken down red blood cells. Crucially, what they will not see in PCV is any vacuolar degeneration of the basal keratinocytes.
No melting.
No civet bodies. No
Yeah.
liquefaction. The foundation, the basement membrane, is completely intact. There is no active structural destruction whatsoever.
So what does this all mean? The clinical exam is sort of like interviewing a bunch of eyewitnesses who all saw a red car speed away from a scene, you know?
Oh, that's perfectly stated.
Right, because one says it was shiny red, one says it was orange red, another says it had a white scratch on the side. It's chaotic and confusing. But the biopsy is like pulling the security footage and zooming in on the license plate.
Yep.
You run the plates, and one plate clearly says T-cell lymphocytes causing structural destruction, and the other plate says plasma cells causing chronic irritation. It takes all the guesswork out of the initial evaluation.
The biopsy gives you the license plate definitively. And this raises an important question, which is, why does getting the right license plate matter so much right now for the patient sitting in the room?
Yeah, it matters because earlier you noted they might both be treated initially with the exact same first-line therapies. Like a doctor might prescribe an ultra-potent topical corticosteroid, like clobetasol 0.05%, or a topical immunosuppressant like tacrolimus for either condition.
Yes, that's standard.
So if the initial treatment is the exact same cream, why do we care so much about zooming in on the cellular license plate?
We care because the long-term management protocol and the patient's prognosis are wildly different. If the biopsy confirms PCV, you are managing a highly localized, benign condition. The patient might need that clobetasol or tacrolimus for an extended period, and the inflammation can be incredibly stubborn, but you aren't racing against a biological clock of permanent tissue destruction.
But if the license plate comes back as ELP, the entire strategy has to pivot.
Oh, completely. If the pathology report reads ELP, the clinical posture must escalate immediately. You are no longer managing a stubborn rash. You are managing a systemic autoimmune disease with a high risk of permanent life-altering scarring.
Which means more intervention.
Yes, confirming ELP mandates rigorous, ongoing monitoring to prevent those senecae from forming. Patients may need to be instructed to use vaginal dilators early and aggressively just to mechanically maintain vaginal patency and prevent the tissue from fusing.
Wow.
And if those topical steroids aren't enough to halt the T-cell attack, the clinician needs to be ready to step up to systemic immunosuppressive treatments, like oral medications that calm the entire immune system.
Because it's systemic.
Exactly.
Yeah.
You simply don't deploy those heavy-hitting systemic drugs for a localized irritation. You deploy them to save the patient's anatomy.
It really puts that 4.7-year diagnostic delay for PCV into a terrifying perspective. Think about a patient with ELP wandering in that same diagnostic wilderness for nearly 5 years, treating it with over-the-counter yeast infection creams while their tissue is slowly, irreversibly scarring and fusing.
It's tragic.
It's a race against time that the patient doesn't even realize they are running.
Which is exactly why the BSH guidelines are absolutely uncompromising on this point. You must take a biopsy when mucosal lesions are atypical, unyielding, or causing severe entrance pain.
No exception.
No exceptions. You cannot afford the risk of managing ELP as if it's just a stubborn, localized issue. The cost of being wrong is simply too high.
Let's bring this all together. What we've uncovered today is that entrance pain combined with red, glazed mucosal plaques demands careful, precise differentiation during that initial evaluation. You cannot rely on a visual guess based on the shade of redness.
No, you really can't.
On one side, we have erosive lichen planus, the autoimmune attacker. It brings a high risk of scarring. It might present with a hyperkeratotic shield of Wickham striae or gum involvement, and under the microscope, it is characterized by lymphocyte-driven basal cell destruction and liquefaction.
And on the other side of the diagnostic divide, we have plasma cell vulvitis, a chronic, idiopathic, localized inflammation that might present with a glistening cayenne pepper look due to leaky blood vessels.
Right.
Under the microscope, it is defined by a plasma cell heavy infiltrate and iron rust stains. But thankfully, it completely lacks the architectural destruction of the basement membrane.
The ultimate takeaway for you listening, whether you are a clinician trying to solve a tough case, a medical student, or a patient fiercely advocating for your own health, is that taking the time to differentiate these conditions via a simple punch biopsy is not optional.
Never optional.
It is the definitive key that can save a patient from years of unnecessary pain, failed treatments, profound misdiagnosis, and progressive irreversible scarring.
The murky diagnostic waters of mucosal conditions are incredibly deep. But given how much the symptoms of these two specific conditions overlap with incredibly common everyday issues like yeast infections or contact dermatitis,
Yeah.
and considering that staggering 4.7-year average diagnostic delay for PCV,
Still blows my mind.
it really leaves us with a sobering reality to ponder. How many patients are currently out there right now? How many individuals are silently enduring what they've been incorrectly told is a recalcitrant or incurable infection, cycling endlessly through over-the-counter creams, entirely unaware that a diagnosable, treatable, and potentially destructive immune condition is the true culprit beneath the surface?